Dear colleagues, first of all, I want to thank the organizing committee for this kind invitation. And in the next minutes, we are going to discuss a very interesting topic regarding the bicuspid aortic valve. And why is that? Because bicuspid valve is characterized by anatomical and morphological heterogeneity, and at the same time, there are several size and issues. Here is the heart team of Idea Hospital. And what we know is that the bicuspid valve is not a so rare situation in the TAVI population. It occurs up to 20% of the cases. And according to recently published data regarding both self-expandable and balloon-expandable valves, we expect that in the future, the TAVI is going to expand in younger population as well. And this type of group of population, it is characterized by higher incidence of bicuspid valves. From the other side, there is a big and huge limitation regarding this group and these anatomical variations, since there are no solid data due to the fact that bicuspid valves were an exclusion criteria for most clinical trials. So regarding the morphological heterogeneity, there are different classification patterns. The most common in use is one coming from Sievers, which classifies the bicuspid valves according to the number of the rafts as type 0 with no raft, type 1 with 1 raft, and type 2 with 2 rafts. And recently it was shown that the most commonly type is the type 1 with left-right fusion, which is characterized at the same time often by an asymmetric non-coronary sinus. And the less common is the type 1 with left and non-cusp fusion with 3% of the cases, and type 2 with 2 rafts in 1% of the cases. And we know that the echocardiography, which is the initial imaging tool in order to evaluate such patients, can lose the true bicuspid valve up to 50%. Therefore, the CT is the gold standard imaging tool in order to assess not only the whole anatomy from the peripherals to the aortic valve, but also to understand different anatomical heterogeneities that occurs. And recently we saw this nice publication which classified the TAVI patients according to the bicuspid valve anatomy according to the leaflet morphology as functional bicuspid valves and true bicuspid valves. And the true bicuspid valves are categorized according to the existence of a raft with raft type and non-raft type, the raft type occurring up to 55% of the cases, and according to the leaflet orientation as coronary cusp fusion and mixed cusp fusion. And when we compare the true bicuspid valves with the true bicuspid valve with the tricuspid valves, we've seen that the bicuspid valves are characterized by larger anatomy, not only at the level of the annulus, but also at the level of the ascending aorta. We have higher coronary ostium, significantly higher calcium volume, and interestingly, they didn't find any severe difference in the ellipticity index. Here is a very interesting slide showing the different anatomical and morphological discrepancies between the different types of bicuspid valve. When we compare the functional valve and the tricuspid valve, we see that the bicuspid valves are characterized by larger anatomies at the level above the annulus and characterized by more calcium volume. And when we compare the bicommissural true bicuspid valve according to RAF and non-RAF type, we see that the RAF type is characterized by larger anatomy at the level of the aortic annulus. However, at the level of the sinuses, we see that it's exactly the opposite. And why is that important to understand the anatomy? Because the anatomy predicts the functional status. And we see that according to the number of the RAF, we have different functional categories with higher incidence of aortic valve stenosis and high incidence of aortic valve insufficiency in cases with 2 RAF, which represents the type 2 according to Sievers classification valve type. And of course, the functional status can affect the mortality in these cases. From the other hand, the type and the existence of the RAF was not associated, according to recently published data, with the aortopathy and the aortic dilatation. We know that often the bicuspid valves combined with aortopathies, and this occurs up to 40% of the cases. There are different types. The type 1, which is characterized by dilated aortic root, up to 39% of the cases. The type 2, which is characterized by the dilatation of the tubular portion of the ascending aorta, and the type 3, which is characterized by the dilatation of the whole ascending aorta and the aortic arch at the same time. And we know that the aortopathies are characterized by higher incidence, up to 5 times, for complications such as aortic dissection, and this it is more often seen with balloon expandable valves, especially when these are oversized. Another information that someone could get from the CT analysis is the existence or not of a horizontal aorta. This is another often combination that occurs. The horizontal aorta may complicate the accurate position of the valves because it can affect the capability to control the delivery system, and at the same time it is characterized by higher incidence of porcelain aorta. And we know that the aortic angulation can affect the procedural success, especially when we use the self-expandable valves. And here comes an interesting example of type 1 valve with left-right fusion and calcification. You see from the CT that there is a horizontal aorta, a huge calcium volume, not only at the level of the annulus, but also a volume of calcium protruded into the LVOT. And from the aortography, you see the horizontal aorta and the dilated aorta. We start with a valvuloplasty using a nucleus 22 millimeter in size. We have not complete sealing. We've seen some paravalvular leakage, and at the same time, the patient experienced VT, which was successfully treated with cardioversion. Thereafter, we decided to deploy the core valve 31 millimeter, which unfortunately were too low in position, were very deep in the LVOT, and that was the reason of the moderate to severe paravalvular leakage. We decided thereafter to proceed with a post-dilation using a nucleus at that time, balloon 28 millimeter in dimensions, but finally the result was not so satisfactory, having a severe AI not only due to the paravalvular leakage, but also due to the transvalvular leakage. Therefore, we decided the next day to proceed with valve-in-valve with an excellent hemodynamic result with mild paravalvular leakage. So in order to the understanding the anatomy of the bicuspid valve is of crucial point, we have a lot of data showing that the type of the true bicuspid valve with existence or not of RAF and the calcification volume can affect the centricity of stent frame expansion and therefore the incidence of paravalvular leakage. And we know that the existence of more than mild paravalvular leakage, it is almost 2 times higher compared to the tricuspid valves, and the need of a second valve in such cases, according to recently published data, it is 8 times higher. Another important anatomical information that often we get is the coexistence of coarctation of the aorta. It occurs at up to 35% of the cases. It is more often in type 1 left to right fusion bicuspid valve, and here comes an example of type 0 bicuspid valve with coarctation. According to the anatomical informations, we decided to proceed with a sapien 3 valve, 29 millimeter in dimensions. There is a lot of calcification at the level of the annulus. The ascending aorta was not so dilated, and of course, it was not so horizontal. We start with a valvuloplasty using an Edwards balloon, 23 millimeter, having a complete sealing with no AI. And thereafter, we, due to the balloon valvuloplasty, we decided to undersize using a sapien 3, not 29 according to the anatomical information of the CT, but with 26 according to the result of the balloon valvuloplasty with an excellent hemodynamic and echocardiographic result. Of course, the CT analysis gives us a lot of information, and there are different sizing strategies. We have already seen the balloon-based sizing strategy. There is also the annulus-based sizing strategy, and from the CT we take different and various informations at different levels of the aortic root, and we can proceed with sizing based on the intercommissural diameter 4 millimeters above the level of the annulus. When we decide to proceed and to size based to the annulus, we need some type of oversizing which must be less than 7 to 10%, and this is more important in evoluent valves. And when do we decide to use a balloon sizing? Here is an example of type 1 left to right fusion, rough calcification, no ascending aorta dilatation. According to the anatomical information, we had to choose between Evolu 29 or Sapien 326. We start initially with the thought of doing the procedure with a Sapien valve. However, during the valvuloplasty, we see that there was a great instability of the 20 millimeter valve, which corresponds to the smaller annulus dimensions, and therefore, based on that, we changed our strategy using finally the Evolutar 29 millimeter with an excellent final hemodynamic result with mild paravalvular leakage. According to the recent published paper, we see that using the balloon, it is very important for the sizing process in such cases with bicuspid valve. And here is a nice algorithm according to the experience coming from the Asia. You know that Asian population are characterized by higher incidence of bicuspid valve. Another important information that we take by the CT analysis is the dimensions of the intercommissural diameter 4 millimeter above the level of the annulus. There are different configuration types when we compare the aortic annulus and this parameter. We have the tube type, which occurs up to 34% of the cases. We have the flare type, which occurs in 52% of the cases, and the taper one, which occurs in 14% of the cases. In the first two configurations and in the first two times, we have to select the size of the valve according to the annulus, but in the third one, the taper one, we have to size based on the intercommissural diameter. And in that case, we must not oversize. Oversizing can increase the risk of complications in such population. According to data coming post-TAVI, using the CT analysis, we see that the prostheses we use in this type of population were almost 10% smaller than the mean annulus diameter at the baseline. And echocardiographic data have shown that the effective orifice area, it is smaller in bicuspid population, and there is a high risk of PPM in such population. However, interestingly, the new generation valves shown that they retain the cylindrical configuration in this type of population, and that reflects to the better result with less complication and less need of a second valve. So, in conclusion, we can say that the bicuspid valve, it is not so rare situation. It is characterized by morphological and anatomical heterogeneity. The CT is the gold standard in order to evaluate the anatomy at different levels of the aortic root. The balloon sizing, it is important stage and step during the annulus sizing procedure. When we have horizontal aorta, we have to use with caution the self-expandable valves. When we have dilated aortas, which are more fragile and there is high risk of dissection, we have to use with caution the balloon expandable valves, and especially when we want to oversize them. And always we must aim at high implantation for better leaflet sealing. And with that, I want to thank you for your attention.
Ευχαριστούμε πολύ. Ερωτήσεις? Sorry. Okay, thank you very much for the presentation. Well, we're ready for questions. Yes?
Well, I will ask something. Do you think that the Sievert's classification will influence the selection of the device? I mean, if it's one RAF or two RAFs or zero RAF or something like that, you choose the device according to this classification, or only if it's balloon expandable or not expandable, or self-expandable?
I think for the choice of the device selection, it is not only the classification of the bicuspid valve. We consider all the other anatomical informations that we have previously discussed, like the type, like the size, like the horizontal aorta, and of course that depends also from the general situation of the patient as well.
Okay. Dr. Chalapas, thank you for your excellent presentation. As we know, the patients with BAV represents a very heterogeneous group. I would like to ask you about the contraindications, which is the main contraindications. Calcified rough, because the patients with the BAV have dilated annulus. In your opinion, which is the main contraindication to the technique?
You mean if the TAVI is a contraindication in this type of population? As we have already said, that bicuspid valve is an exclusion criteria in most clinical trials. So we have data from different registries and observational studies, and of course that depends on the surgical risk of the patient, and that depends also if it is contraindicated for a real surgery or not. We often see the true bicuspid valves in younger populations, so we have to consider very carefully if we use this type of procedure or not.
Okay, thank you.
Seems like it doesn't probably matter that much if we replace big stenosis, critical stenosis on an older patient, a non-surgical candidate with a valve, and we leave him with a 2+ regurgitation. He will tolerate that better than the significant degree of stenosis he had before. Now, when we're moving to the lower risk patients, I don't know if we should tolerate that degree of regurgitation, and that's for regurgitation in general, the paravalvular regurgitation. And if you notice, they have excluded the bicuspid valve from the studies, from both studies. I think we should worry about that. We know regurgitation influences survival. These patients, they are younger, they have no comorbidities, and they have long life to live after the procedure. No matter how better valves we have designed, here at the level of the valve, we have deformity. We don't have a nice annulus, round annulus. We have calcification, and sometimes we do have some disease on the wall of the aorta at that level, on a bicuspid valve patient. I think we should worry a little bit more about it. You have anything to say?
I agree that we have to be more cautious when we choosing younger population with bicuspid valve. This procedure, however, our experience is satisfactory when we use this procedure in older patients with bicuspid valve. So I think that we have to individualize, but until we have solid data from trials, we have to be very careful.
Thank you very much, and that takes us to the next speaker. Is Dr. Van Megen.